Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice in any situation. Please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you're unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, welcome to the Glasses Half Full podcast. As you can see, I am now introducing the podcast.
Thank goodness for that.
We have a little bit of a change up. We actually have a guest for once. So
Somebody actually agreed to talk to us.
I know. It's
Willing though.
I'm not a paid actor.
We're definitely not paying anyone.
So Patrick is a clinical optometrist. He works in a cataract clinic at Optometrist. I can say the company name, right?
I think so, yeah.
I think so, hopefully. So we're literally just going to ask you some questions, I guess, have a little bit of a chat. I think a lot of people, especially in the UK, that are optometrists are mainly based in like community, your multiples, your independents, essentially normal routine sight tests, glasses, refer if there's a problem.
Yeah.
So we'll start off with actually more on you and how you got into optometry, and more specifically how you got into like a cataract clinic and what made you decide to make that jump.
Yeah.
So you didn't start as optometrist, which is really interesting. I quite like the fact that you have had a few other jobs in between. So where did it all begin?
So 18 years old, got dragged to a job fair because I kept on dropping out of college and kept on being a general reprobate, not really going anywhere in life. And I just randomly ended up at an Optical Express job fair one day and just got employed. I'm now 35, check that a second. So 18 years old, and I was set on as an optical assistant, but actually they wanted to refer to me as a runner at the time.
Okay.
So essentially my job was just to run around after everyone on the shop floor. So that's where it started.
So what does that involve? Because I've not heard of that.
Is that
So
like,
it's kind of like old school optics. So a runner is essentially someone answering phones, or they might shadow like the main dispenser to like run the job to the lab.
kind of like an apprentice.
Kind of like like at the low end.
Yeah.
Like the bottom end.
An extra pair of hands.
Extra pair of hands. That's what I say. Answering phone, booking appointments, etc., etc. And it just grew from there. So learned dispensing, and then I learned how to become a patient advisor, which was called a refractive counsellor back in the day, which is the person seeing the patient after the optometrist has done a consultation, so assessing up suitability and then booking surgery if they're a suitable candidate. From there, I then went and became an assistant manager of a small clinic in Barnsley. Yeah. Again, same company, with the same company for 17 years, Optical Express. Then I went from there to assistant manager of the surgery centre in Meadowhall, which did laser eye surgery. Then from there to general manager of Derby, and then from Derby to Nottingham, which is like a IOL and laser surgery centre. Then from there I went back to Meadowhall, so back to my roots, but as a clinic manager. Somewhere in the middle of that, I qualified as a dispensing optician, so I did the 3-year degree with Bradford College.
Okay.
It was on a day release basis, so just attending college once a week and then doing the practicals in between. Then I became a regional support manager, and then they progressed me to regional manager. So I got to regional manager, and then I thought to myself, I want more than this. I don't want to just be the commercial guy. And I wanted to just give my career longevity, and I knew that the way to do that would be through optometry. So I applied for the traditional route through university. They declined me because I didn't have the A-levels for it.
What, like 15 years prior? Or
10
years prior?
So that was my argument. So my argument was, well, I've got more than that, but just purely
I've done a third of the degree already.
but they didn't want to know.
crazy.
is fine. It's whatever. University have got the entry criteria. It's all based on points, isn't it? And academia, which was never my strong point in the first place. But then I found out about the accelerated route through Bradford University, the career progression course.
Is it 1 or 2 years? That one?
Technically 18 months.
18
Somewhere
Yeah. So I applied for that because it's designed just for DOs. They accept about 20 applicants every year.
Yeah.
I got accepted and then lived in Bradford for a year. Suffered that.
Made it out alive.
Put about 3 stone on. Well, all the takeaways. I'm not bothered. It's fine. It's true. Enjoyed my time. Became an optometrist. Did my pre-reg with Optical Express, and then from that, because of my background with refractive and being a regional manager, they put me on to consultations. I think within a year of being qualified.
Yeah.
They didn't really say you have to. It was more, it's an option if you want it.
Yeah.
And because of my background, they let me do that and did consultations, post-operative work with them for 2 years. And
This is more for laser eye surgery.
Yeah, so for laser eye surgery, lens replacement, fake kick, that kind of thing. And then from there, so I spent 3 years as a qualified optometrist with Optical Express, and then the opportunity came up with Optegra.
Nice.
So I've only been with them for a month.
Oh, okay, fair enough.
Yeah, so
Going well?
Going well, mate. Yeah. First time in a new job for 17 years. So weird,
Well,
but
you say that, but you've had about 17 different job titles.
yeah.
Like, okay, you've been with the same company, but you've every corner of the field you've worked and excelled at.
Especially in the commercial aspect of it. So I guess it's comparing like your career. It's a very short amount of time that you're actually being like a clinician in comparison to your whole career.
Definitely.
It's quite a new thing for you at the moment.
Yeah.
3.5 years qualified, is that roundabout right?
Yeah. Well, 3 years just.
3 years just.
Yeah,
okay.
but my pre-reg took
So
about
COVID,
18 months. Yeah, that's right.
Fair enough.
So my pre-reg took longer than expected because of COVID.
Yeah.
So yeah. But
So with
How was furlough? What did you spend your time with?
fine, mate. Yeah. Just got a suntan, put more weight on.
Standard
beer,
story.
Played my guitar, thought, I'm going to get back into guitar. Dropped it as soon as we came back.
with that kind of like change in turn, I guess, in your career, what have you noticed more, let's say from the non-optic side of it to being an optician? Is there anything that kind of shocked you, or you felt the difference when you were an optician?
I'd like to think not, in a sense of I had an appreciation for the role prior.
Yeah.
I prefer it in a sense of my only responsibility as a person sat in front of me.
Yeah.
And that was probably one of the biggest driving factors in wanting to change from management to optometrist.
Yeah.
When you're a manager, everyone and everything is your responsibility, which is nice in a way when it all goes right.
Yeah.
And when it all goes wrong, you're also responsible. Didn't go wrong very often, but it's nice. For me, I just like being in control of myself and the person sat in front of me.
Fair enough.
So that's the biggest difference between the two.
Yeah. And you're quite new to Optegra, so Optegra is like a cataract clinic mainly, isn't it? So is there any differences that you notice between working in a cataract clinic and working as a community optometrist?
Oh yeah, massive. The thing is, with my previous role, it was more, like you say, commercial.
Yeah.
So every patient I saw with Optical Express was private. So every patient sat in my chair is spending somewhere in the region of £4,000 to £8,000 for the surgery, generally speaking. So the expectation level is completely different.
Yeah.
In a sense of they wanting visual freedom,
Yeah.
whereas the patients I'm seeing at Optegra just want rid of the cataracts.
Yeah.
So it's far easier to keep the satisfaction levels higher where I am now than where it was.
Yeah, because you're like,
Right,
we're just going to make it better than what it is now.
Yeah, you're still going to need glasses.
Yeah.
The bar is just much lower.
Yeah, that's it. Yeah, but in a good way.
Yeah, absolutely.
Even so, prior to the patient even hitting my room, they've had like a full screening assessment. So they've had all their observations done. So they've had the blood pressure measured, they've had tropicamide instilled, they've had all the medication recorded, they've had the vision checked, so unaided. Then they've had
Who does that?
the healthcare technicians, and a nurse as well does like the pre-op stuff. So everything's taken care of essentially. So when they hit my room, I'm there to check pathology,
Yeah.
make sure they understand what they're there for,
Yeah.
and to consent them properly. So that's essentially my. There's no refraction anymore,
Yeah.
which is a blessing.
The most fulfilling part.
Oh
So
God!
I guess it's just basically purely like a clinical role then.
Yeah, far more clinical. There's no, not that there was a pressure to sell previously.
Yeah.
Realistically, that pressure's always there, but I never approached it from, oh God, I've got to book so many patients today, because I don't care for that.
No.
My priority is telling the patient what they're suitable for,
Yeah.
tell them the risks, be honest with them, and then it's up to them to make an informed decision.
Yeah.
And I think if you're honest with people, they would convert anyway.
I find that because it's I'm quite lucky that very, very few places I've actually worked at, and as a locum, you work in a lot of places. I've had the direct pressure to sell.
Yeah.
But even though I might not have the direct, conversation or the direct insinuation or statement, that indirect pressure that, this is a place that doesn't run on, happiness and dreams. It's a place that requires that rent needs to be paid, etc.
Yeah.
So indirectly, so to go somewhere where there isn't even that indirect pressure, that must have been a weight off your shoulders just day in, day out.
Yeah, and like I say, I never really felt that way anyway, because I don't operate like that. I'm going to do what I think is right. And in sales, if you do what's right and be honest with people and upfront. So say, for example, you get somebody through the door for a consultation, and they're a suitable candidate for surgery. We're talking about my previous role more here, but they're not a good candidate. I'll just say that. I'll just say, look, you're suitable, but that doesn't mean you should have it.
Yeah.
Okay.
But by doing that, you've been honest with them, and they're going to go home and go, do you know what? They were really honest with me. They were upfront. They seemed really truthful. And by that, you're going to get more referrals and people booking anyway.
That's true.
That's true. But I mean, there is still obviously a need to convert where I am. But it's more a sense of, is the patient suitable? Yes. And then the NHS will pay the company the fee for treating them.
Yeah. Fair enough. I hear, or I've heard, mainly from DOs, a lot of, I don't know if this is just trying to maintain their job security, but let's give them the benefit of the doubt. Previously, when there were OAs, optical assistants, and they were dispensing, etc., they could do varifocals, blah, 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 they felt that, I'm basically a DO because I can do everything that the DO does. We just need their sign-in details for the under 16s or for the prisms or whatever it may be.
Yeah.
And then when they become a DO themselves, to get that extra, whatever it is, managerial position or responsibility or flexibility, whatever it may be, they realize that, hold on, there's a lot more that I didn't see. Being somebody who has had the fortune to work in so many different areas, what are some of the biggest things that hold on, I didn't realize that job role had so much more that I didn't see behind it.
Are you talking about DO or just any?
I've noticed it with DOs, but did you notice that as an optician? Did you know becoming an optometrist, or did you notice that becoming a manager or a regional manager, or did you notice anywhere that's like, hold on, there's so much more I had no idea?
Do you know what? Every role.
Yeah.
I think you have to have an appreciation for every role. Every role carries an important responsibility, whether it be picking the phone up to triage somebody, or even just simply picking the phone up to book someone in for the right appointment and making sure that they're in with the right person, or that they've got the right amount of time, or as a manager, making sure that your team are well prepared and know what they're doing. As a dispensing optician, even as a DO, you've got a responsibility to refer and understand pathology to a certain degree. And even being in theatre today, like, you can just see the guys that have been running around clinic, they're so professional and skilled in what they do. You just can't take any role for granted. So I don't necessarily look at a team and like, rank them in terms
Yeah,
of
no,
like.
of course.
So the cleaner is just as important as the optom sometimes. In some
But was there any like surprises once you got into a role? Is there anything that you didn't realize that, hold on, there was this thing which I had no understanding of?
Probably optometry.
Is it?
Yeah, just like the weight of responsibility of missing something. I suppose knowing like how I was as a manager in the past, squeezing a walk-in in, or trying to cram that extra.
Yeah, no, of course.
You're going to do it when you're in a commercial position. Like, you just want the sale because I've got someone on my back demanding sales. Yeah. I'm trying to make money. I don't necessarily realise the knock-on effect it has for the optom, or even lack of referral, like how time-consuming that can be, especially if you don't know the pathway. So yeah, I'd say that's probably one of the biggest things.
But I guess that jump was the jump from the biggest jump from commercial to healthcare, commercial to clinical. Yeah. It was a jump into being an optometrist.
Yeah.
So that would make sense.
So I'm quite interested in your current job, and especially the clinic that you run, and what you actually do when you have the patient. So you did briefly go over a little bit, but when it comes to as an optometrist, and you're not refracting, a lot of the tests are already kind of done for you.
Yeah.
So when you're looking at the pathology, is there like like what are you looking for, and what are you just explaining to the patient?
It's just like, yep, that's a cataract.
Yeah. Like, oh yeah, no, right.
Yeah, you got cataracts, mate. Do you want it? Yeah.
7 people told me that.
Do you know what I've realised is how crap I was at like describing a cataract
to a patient?
Yeah, not to a patient, no. But as an optom, just bilateral cataract, dense cataract, moderate, NS, whatever.
Just in your notes.
Yeah, but actually, when you've got a dilated pupil and you're looking at the cataracts, and actually, how nuclear is it? How cortical is it?
Yeah.
Is there a posterior subcapsular element to it? So it's my skill in describing a cataract, I feel like has shot through the roof because I'm just looking at the lens completely differently as before, and the way I'm like spending time at looking at the lens has changed quite a lot. Yeah.
And I'm sure the surgeon will appreciate every extra detail.
But that's the thing, it has a massive knock-on effect. So again, this is all new knowledge to me. There's something called a PCR rate. So each ophthalmologist has got a graded on the like PCR rate. So it's posterior capsule rupture rate.
Yeah.
So how many bags split through surgery. So it's like a ranking for them. Yeah. And each patient that you grade, it'll give you like a PCR risk at the bottom. But if you've got a really dense cataract, and if it's like a particular type of cataract, that increases the risk.
Are we talking more like Morgagnian types?
Like what, sorry?
Like Morgagnian, like the really dense one.
Yeah, so like a cataract I didn't even know existed called a posterior polar cataract.
Yeah, obviously.
It's just like a planet. It's like a proper dense planet in the middle of the lens, but posterior. No.
Does that carry a high risk or a low risk?
High risk, because it's quite dense and it's attached to the posterior part of the bag. Yes. There's a higher chance of it rupturing as they're removing it. So there's things like that, really. So I'm grading the cataract. I'm looking at the cornea. So I'm really looking for guttata. So I'm looking for any sort of corneal dystrophy, because if there's an endothelial dystrophy, it increases the risk for edema, corneal edema, which every patient's going to get to some extent. But if there's a real high amount,
prognosis won't be as good.
Yeah. Well, potentially, if worst case scenario, if there's really bad dystrophy, then it could end up in a transplant, corneal transplant graft. So you look at, but again, didn't know this, but surgeons have got the option of using a different type of viscoelastic material to put into the eye, which can prevent. So, like if a patient has got Fuchs or some sort of endothelial dystrophy, they can use a different type to prevent it from becoming a problem. Yeah. So by me knowing that, it was not necessarily going to stop the procedure from happening, but it just gives that surgeon the heads up as to this patient has this,
Yeah.
so alter your surgery accordingly. And also from my perspective, I can consent them properly by saying, you have this, therefore there's a higher risk of this, worst case scenario.
Yeah.
Yeah.
Interesting. Is there a discussion that you basically have with, like, in terms of the management that you have? Is there a difference in the management that you would do? So would there be a point where you'd be like, look, you have this depth cataract. It's not going to do much if we do this surgery anyway. It might improve your vision by a line because you have, let's say, AMD or something like that. Would you be doing that kind of discussion with them, or is it a bit more in depth, as in, like, can you give like an estimation of the prognosis that they get based on the cataract that you see?
Yeah, so it's called a guarded prognosis. So it's where you just discuss additional risk factors and tell them the likelihood of problems from that.
Yeah.
So, for example, patients diabetic, higher chance of CMO.
Yeah.
Some vitreomacular traction, higher chance that causes a problem at the back of the eye. ERM, they're all risk factors, all guarded prognosis, macular degeneration.
Yeah.
So yeah, you factor it into your conversation. Yeah.
What type of contraindications would you find? Or what's something that a patient comes in and you're like, you are not getting your cataract taken out, apart from, say, they've got advanced glaucoma, advanced RP, and there's just no point.
Yeah. What would really stop it?
Or
I
just get them all
suppose.
done.
Yeah, whack them all out. We need the money. Do you know what? Overwhelming majority are going to have it done.
Yeah.
Because they're there for a reason. They've got bad cataracts. It ain't going to get any better. Most of these patients are old, so the health is declining, as everyone's does as you get older.
Yeah.
The cataracts isn't going to get any better. Clinically, are you going to leave it a bit longer and let the cataract get worse and wait for the patient's health to deteriorate, where they're not in a position to come through for surgery?
Yeah.
So you just make the call, really. I don't suppose there's like, some things are barn door. So, for example, if you've got an amblyopic patient who the amblyopic eye is
suppressed
660 or whatever,
Yeah.
it's crap, and the cataract eye is, say, 6'9", do you really want it doing? Because there's a 1 in 1,000 chance you're going to lose your sight in that eye. You've only got one eye.
Yeah.
Are you willing to take that risk at this point? You're still in driving standards. Is it worth your while?
Yeah.
Probably not. Yeah, probably not.
Where would you draw that line? For that, say for this hypothetical patient that is very, black and white, and of course is a lot more three-dimensional than this, but say you have a patient that is driving, say they're 65, amblyopic right eye 660, left eye 6'9". Would it be the standard 612 until they can't drive anymore? Is that what you'd call it?
Do you know what? You just put the ball in the patient's court.
Yeah.
Just be honest with them. Like, this is the situation. You're on the cusp of driving standards at this moment in time. Is that something you want to risk, or do you feel like you can cope with it? But I suppose it still goes back to the fact that it ain't going to get any better. And it depends how much it's bothering the patient as well. So yeah, it's not for me to make that decision.
Yeah.
It's for me to tell the patient their situation and then for them to decide.
Is there any cases in which, let's say, you get that referral from, let's say, the community for cataract surgery, but they have other ocular conditions that require treatment that may contraindicate the surgery at the time? Have you had that come across?
That may contraindicate surgery?
Yeah, I don't know, possible other conditions that require treatment
prior to
the cataract.
Yeah.
Have you had that before, and is that something that you would refer, or would you see them back, or how would you go about dealing with things like that?
Well, my short time with Optegra, we've had a patient who had a bit of had a PVD.
Yeah.
He was like sat there and was like, oh yeah, so what took me to the opticians was I saw this flashing light and then I got this float and I'm like, why is that here, mate? Cheers for referring to a cataract clinic. And then peripherally, you could see the vitreous just pulling on the retina, and there was some like hemorrhage in there.
Oh, delightful.
Right.
So that needs resolving first. Did urgent referral to a VR clinic. Said, look, let's get seen by a VR specialist. Make sure that you're not at risk of retinal detachment or there isn't an RD starting in the periphery.
So this, what you would call an emergency referral, was to a cataract clinic.
Yeah.
How long after were they?
So it was relatively quick, probably about a week,
Yeah,
and it wasn't. Yeah, and it wasn't. I know it sounds like barn door, but to be fair to the optom that referred, it's still the way that the patient was describing it, because he was like, "Oh, but I was at a concert and there was loads of flashing lights anyway." So he was almost like disregarding it.
Yeah.
But actually, when you listen to the patient and then you see the dilated eye, you're like, "That's not right."
They might not dilated with those.
Yeah,
with those
yeah. You'd hope they would, but
of course, but
yeah. You know what it's like.
So just to move on, I guess, to a couple final points for this episode. I want to get more on the clinical development side. So obviously you're now an optometrist.
Yeah.
You're working as a clinical optometrist. I call it a clinical optometrist because you're not doing anything.
I know you mean.
So that's
yeah.
why I say that.
We're all clinical. We're all clinical.
Yeah, you aren't clinical.
What kind of developments would you see as an optician? How much development is there at this point in let's say your career? Is there any more surgical developments that they can do, specializing that you can do as an optometrist?
Yeah.
Do you know anything in that regards?
Well, I'm IP now.
Yeah.
So I'm an IP optom.
Ooh, it's fancy pants.
Yeah. Higher level. I'm not higher level. FYI, when you become IP, you don't just start prescribing right, left, and centre. You still cack your pants every time you see. Yeah. And realistically, even as an IP optom, you still refer to ophthalmology. I think IP is really useful for those like me that are in the refractive setting.
Yeah.
Because we see a lot of CML uveitis.
Yeah.
We don't have to go running to the surgeon to ask to prescribe. But in a community setting, I think IP is still a bit scary, but it's there.
So have you used it in your clinic? Or can you use it?
Yeah, I've used it, yeah. So I've used it more so in my previous roles. I haven't really seen follow-ups at Optegra yet. But yeah, kind of getting off topic a bit there. So yeah, there's IP, which is really useful for anyone in my kind of position. And they're going to teach me YAG soon. So I'm going to learn how to do some YAG. So that'll be cool. Blasting a laser.
That's very exciting.
Yeah, it's good, yeah. And that's what I like about it. It's that variety. It's not I think every job becomes mundane at some point.
Yeah.
You do the same
Especially
stuff,
optometry, because it's the same routine. Everything's the same, isn't it? It's copy-paste pretty much. But at least with my role, it's a bit more hands-on. And there's more, for me anyway, there's more like branches to it, and there's places I can go with it. And I think with the way that optometry is moving, I think it's going to come to a point where the optoms that are more highly paid or the ones that are more in demand are the ones with the qualifications that can do additional things.
Yeah.
So for me, that's another reason for doing
covering your bases.
Yeah.
So I feel like we just brushed over that. You're going to learn how to do YAG.
Yeah.
That's huge. That's huge.
Yeah.
So it's okay. So and that's anything else? Or I mean, not that that's not enough.
So the good thing with learning how to do YAG is that I'll be able to do SLT as well. So not straight away. I think I'll need a glaucoma certificate.
Yeah.
But I'll be able to.
But now they're getting so common. Now it's like it's becoming like almost the default treatment.
Yeah, that's it, mate. And NHS is so overwhelmed. They're going to have to farm the work out. So and who comes next in terms of offering those treatments? It's got to be optoms.
Yeah.
So I mean, it makes sense.
Yeah, so that's pretty cool.
So is that something that you were offered, or clearly you're somebody who does seek out opportunities to advance, etc.? Is that something you have to look out for, or was there like a course, or was it like a step-by-step process that you could get to a further qualified optometrist?
So it was something I've been interested in, and I went to 100% Optical. Is it this year? It was this year, yeah. And saw some of the YAGs there and got interested by it. But yeah, it's just something I asked before I started. I said, "Is it an option?" And they said, "Definitely." So basically, until I learn YAG, the clinic in Sheffield won't be able to provide YAG.
Yeah.
Because we only bring the surgeon in for surgery. Yeah. So I think it's more of like a must, or like an essential part of being there.
So they're really, because they're waiting on you then.
Yeah.
Chop shop.
Yeah. Come on, man. Yeah. You're 3 years qualified now. What are you doing, Yag?
Come on. What are you waiting for? Goodness, that's terrific.
That's great.
That is amazing.
A lot of different points I think that we covered in this episode. Very interesting to hear about how essentially a clinic runs in the cataract clinic. So thank you very much for watching or listening. We will catch you in the next episode.